Medical treatment of glaucoma. So first of all, it is very important to attempt to maximize adherence. So provide an explanation of the disease to the patient and rationale for treatment and discussion of the medication which is prescribed and the technique and timing of the administration of the drops and its potential adverse effects. So all these are essential. The provision of written information, it may be helpful. Most glaucoma medication are administered topically, but significant systemic absorption can still occur with resultant systemic adverse effects. So the systemic absorption may be minimized by lacrimal occlusion following instillation, and this can also be done by simply closing the eyes for 3 minutes. So it will reduce systemic absorption by about 50%. And this can be enhanced by applying digital pressure over the lacrimal sac. So it will further reduce systemic absorption. And so these measures also prolong eye drug contact. The effects on the periocular skin may be reduced by blotting overflow from the eyelids with a clean, dry tissue immediately after instillation. Glaucoma medication should be avoided in pregnancy if possible, with systemic carbonic anhydrase inhibitors perhaps carrying the greater risk due to teratogenicity concerns. Prostaglandin derivatives. The major mode of prostaglandin action is the enhancement of the uvuscleral aqueous outflow. Aqueous outflow. Although increased trabecular outflow facility and other mechanisms have been identified, their IOP lowering effect is typically greater than alternatives, and a reduction of 27 to 35% from the baseline can be expected. So reduction of 27 to 35% from the baseline can be expected. A prostaglandin derivative is typically preferred to a beta blocker as the first line treatment for glaucoma because the beta blocker potential for systemic side effects. Duration of action may extend for several days. Duration of action may extend for several days, though administration once every day at bedtime is generally recommended. So once every day is generally recommended. Systemic side effects are few. The most common troublesome ocular side effect is conjunctival hyperemia. So conjunctival hyperemia. If one prostaglandin failed to show adequate efficacy, inter-individual receptor variation means that an alternative preparation may be superior in a given patient. Paradoxically, the concomitant use of more than one prostaglandin can cause a rise in IOP. So there are many prostaglandin derivatives like latanoprost, travoprost, bimatoprost and teploprost. So first one is latanoprost. Latanoprost may cause fever, ocular adverse effects than other PG agents, and so is often used the first line, and approximately 5 to 10% of patients show no response, and the IOP reduction of less than 10% to latanoprost, but may respond to one of the other prostaglandins. And there is travoprost. Travoprost is similar to latanoprost, but fewer patients tend to be non-respondents. Polyquad is a novel proprietary preservative introduced by a major pharmaceutical manufacturer in its travoprost formulation that may reduce ocular surface related adverse effects. So name is Polyquad. polyquad. And there is bimatoprost. Bimatoprost 0.03% has a slightly greater IOP lowering effect than latanoprost, but is more likely to cause conjunctival hyperemia. So a new 0.01% is a newer agent and has a comparable IOP lowering effect to a latanoprost with less hyperemia. Preservative-free bimatoprost is also available. Sustained release intracameral bimatoprost is undergoing clinical evaluation, and preliminary results indicate that IOP control can be achieved in up to 70% of subjects for 6 months with a single injection. The last one is tafloprost. Tafloprost is a relatively new prostaglandin derivative and was the first available in preservative-free form. Its IOP lowering efficacy may be slightly less than that for other prostaglandin agents, but it is well tolerated and seems to cause less disruption of ocular surface. So latanoprost, travoprost, bimatoprost and tafloprost. Now the side effects. The first one is conjunctival hyperemia. It is very common. There is also eyelash lengthening, thickening of the eyelashes, hyperpigmentation, as can be seen in this picture, and occasionally an increase in number of the lashes. So they can also be used for these functions. Also there is irreversible iris hyperpigmentation, as can be seen in this picture. It occurs in up to a quarter of patients after 6 months. The highest incidence is in green-brown irides, less in yellow-brown irides, and least in blue-gray-brown irides. It is caused by an increase in the number of pigmented granules within the superficial stroma rather than an increase in the number of melanocytes. Iris nevi and freckles are not affected. Also, there is hyperpigmentation of periocular skin. It is common but reversible. There may be periocular atrophy, as shown in this picture. Preoperative use of prostaglandin agents may increase the likelihood of cystoid macular edema following cataract surgery. This is more likely to occur if prostaglandin agents are used in the post-operative period, particularly if there has been vitreous loss at the time of surgery. Anterior uveitis is rare, but prostaglandin should be used with caution in inflamed eyes. Promotion of herpetic keratitis can occur, so prostaglandin should be used with caution in patients with a history of condition. Systemic side effects include occasional headache, precipitation of migraine in susceptible individuals, malaise, myalgia, skin rash, mild upper respiratory tract symptoms. Next is beta blockers. Next type of medical treatment is beta blockers. They reduce IOP by decreasing aqueous production. They decrease aqueous production mediated by an effect on the ciliary epithelium. A reduction of 21 to 27% occurs from baseline can be expected in most patients. So in prostaglandin it was 27 to 35%, while here it is 21 to 27%. In approximately 10% of cases, the response decreases with time. It is known as tachyphylaxis. Sometimes within only a few days. There may be limited supplementary effect if a topical beta blocker is prescribed for a patient who is already on a systemic beta blocker. The combination may also increase the risk of systemic side effects. Beta blockers should not be instilled at bedtime, as this medication may cause a significant drop in blood pressure while the individual is asleep. So it causes decrease in blood pressure. So while the individual is asleep, thus reducing optic disc perfusion. So it causes optic disc perfusion to decrease and potentially causing visual field deterioration. The IOP lowering effect is also believed to be less marked during sleep, as nocturnal aqueous production is normally less than half the daytime rate. So the IOP lowering effect is also believed to be less marked. However, a beta blocker may be prepared under circumstances such as monocular treatment to avoid the cosmetic disadvantage of the asymmetrical periocular skin darkening and or conjunctival hyperemia with a prostaglandin. So beta blockers are also prepared in conditions such as ocular inflammation, cystoid macular edema, or where there is a history of herpes simplex keratitis. Now the side effects. The ocular side effects are few but include allergy and punctate keratitis. Granulomatous uveitis has been reported with metipranolol. Systemic side effects. Though severe problems or rare deaths have been associated with topical beta blocker use. The first one is bronchospasm. The bronchospasm may be fatal in asthma or other reversible airway disease, and it is critical to exclude a history of asthma before prescribing a beta blocker. About 1 in 50 patients without asthma will develop reversible airway disease, requiring treatment within 12 months of commencing a topical beta blocker. Next is cardiovascular side effects. There is strong suggestion that cardiovascular mortality is higher in patients taking topical beta blocker. Effects include heart block, bradycardia, worsening of heart failure, and hypotension. Induction of the latter by topical beta blocker having been reported as a common cause of falls in elderly patients. The pulse should be assessed before prescription. A peripheral vasoconstrictive effect means that they should be avoided or used with caution in patients with peripheral vascular disease including Raynaud phenomena. So these are the side effects. Unpleasant but less severe side effects include sleep disorder, reduced exercise tolerance, hallucinations, confusion, depression, fatigue, headache, nausea, dizziness, decreased libido, and dyslipidemia. Alopecia is uncommon but it is reversible on stopping the beta blocker medication. So they can cause asthma, heart block, and predisposed individuals. Now what are the beta blocker agents? The first one is timolol. Timolol is available in various forms including 0.25% and 0.5% solution. It is used twice daily. There is no evidence of a clinically significant difference in efficacy between the two solutions concentrations. Gel forming preparation of 0.1%, 0.25%, 0.5% are used once daily in the morning. Another one is bitoxolol. Bitoxolol 0.25% and 0.5% twice daily has a lower hypotensive effect than timolol. However, optic nerve blood flow may be increased due to calcium channel blocking effect. Bitoxolol is relatively cardioselective beta 1 receptors and is therefore less likely to cause bronchoconstriction. Another is lubinolol. It is a long-acting beta blocker and is used once or twice daily with a similar profile to timolol. Another is carteolol. Carteolol is twice daily, similar to timolol, and also exhibit intrinsic sympathetomimetic activity, more selective action on the eye than on the cardiopulmonary system, and so may have a lower systemic side effect incidence. The last one is metipranolol. Twice daily is similar to timolol but has been linked with granulomatous anterior uveitis. So these are the different agents: timolol, bitoxolol, lubinolol, carteolol, and metipranolol. Next type of medicines are alpha 2 agonists. Alpha 2 agonists. So the ocular alpha 2 receptor stimulation decrease aqueous synthesis. An effect on the ciliary epithelium. They act on the ciliary epithelium. They also increase UV scleral outflow. There is probably a neuroprotective effect. This medication crosses the blood-brain barrier and should be used with great caution in young children. In whom severe CNS depression and hypotension have been reported. Contraindicated under the age of 2 years. They may potentiate vascular insufficiency. They should not be given with oral monoamine oxidase inhibitor antidepressants due to risk of hypertensive crisis. So what are the agents? The different agents are: number one is brimonidine. 0.2% twice daily is a single agent, generally has a slightly less marked IUP lowering effect than timolol. Allergic conjunctivitis is common, as shown in picture E. Allergic conjunctivitis is common, but onset may be delayed for up to 18 months. So epinephrine 1% or 0.5% is used principally to prevent or treat an acute rise in IOP following laser surgery on the anterior segment. So epinephrine 1% or 0.5% is used principally to prevent or treat an acute rise in IOP following laser surgery on the anterior segment. The 0.5% concentration is typically used as a temporizing measure over the course of several weeks, such as while the patient is awaiting for glaucoma surgery. It is not suitable for long-term use because of loss of therapeutic effect over weeks to months and a high incidence of topical side effects. Carbonic anhydrase inhibitors. They are chemically related to sulfonamide antibiotics. They lower IOP by inhibiting aqueous secretion and via the topical route are used 3 times daily as monotherapy or twice daily as adjunctive treatment. So they inhibit aqueous secretion. In general, they are slightly less effective than beta blockers but may have a supplementary neuroprotective effect. They precipitate corneal decompensation in patients with corneal endothelium dysfunction. Idiosyncratic bone marrow suppression can occur, though cross reaction is uncommon. Topical and systemic carbonic anhydrase inhibitors are relatively contraindicated in patients allergic to sulfonamide antibiotics. Research suggests that concomitant treatment where a topical and systemic carbonic anhydrase inhibitor does not usually give an additive effects. The different agents are darzolamide. So darzolamide, the main adverse effects are stinging and a transient bitter taste following administration. Allergic blepharoconjunctivitis may occur but is uncommon. And there is brinzolamide. Brinzolamide is similar to darzolamide but is less likely to cause stinging and local allergy. It is a suspension and a white residue may be left on the eyelids after installation if excess is not wiped away. Next is myotics. Myotics are cholinergic agonists. They are cholinergic agonist. That are predominantly used in the treatment of angle closure glaucoma. For angle closure glaucoma, angle closure. They can be useful in patients with a pseudophakic or aphakic glaucoma. In angle closure glaucoma, miotic induce contraction of the sphincter pupillae. They pulls the peripheral iris away from the trabecular meshwork and they open the angle. Miotics also reduce IOP by contraction of the ciliary muscle, which increase the facility of aqueous outflow through trabecular meshwork. Local side effects include miosis, so they can cause miosis, broache, myopic shift. They can also cause exacerbation of the symptoms of cataract. Visual field defects appear denser and larger. Systemic side effects are rare but include confusion, bradycardia, bronchospasm, GI symptom, and urinary frequency. The different agents are: number one is pilocarpine, 0.5%, 1%, 2%, 4%. As 4 times daily monotherapy is equal in efficacy to beta blockers. Pilocarpine gel is a pilo in the name of Phylogel, 4%. It is discontinued in UK in 2011, but it is instilled once daily at bedtime so that induced myopia and miosis are predominantly confined to sleep. Gel or drops twice daily may be used to prevent angle closure following laser iridotomy in the presence of substantial non-pupillary block element. Another is carbachol. Carbachol is an alternative to pilocarpine. Also, there are combined preparations with similar ocular hypotensive effect. To some of the individual components improve convenience and patient adherence. They are also more cost effective. The example include Cosopt, Zelacom, Timpilo, Combigan, Dutrao, Gainfort, Tepticom, Izerga, and Simbrinza. The new topical medications, the first one is latanoprost bunod. Latanoprost bunod 0.02%, 0.024%. In the name of Yzelta is a new FDA approved topical medication that reduces IOP significantly. So this latanoprost bunod has a dual mechanism. It has a latanoprost component which increases outflow through the uveoscleral route, and it has a butadiol mononitrate component undergoes further metabolism in the anterior chamber to produce nitric oxide, which has an effect on the trabecular meshwork leading to enhanced aqueous outflow. It is used once daily and reduces the IOP more effectively than latanoprost alone. It has a similar side effect to other prostaglandins. So it has a dual effect. It has a latanoprost component and it has a second component, butanediol mononitrate. In the new topical medication is Rho kinase inhibitors, also known as ROCK. So the ROCK, they are novel class of topical medications that increase outflow, of aqueous through the trabecular meshwork. Drops are instilled once daily and are effective in combination with latanoprost in the name of Rocklatan. Rho kinase inhibitors are slightly more effective than latanoprost in reducing the IOP. So another is systemic carbonic anhydrase inhibitors. Systemic carbonic anhydrase inhibitors are generally used for short-term treatment, particularly in patients with acute glaucoma. They are used for acute glaucoma. Because of their systemic side effects, long-term use is reserved for patients of high risk of visual loss. Sulfonamide allergy is relatively contraindications. The first agent is acetazolamide. Acetazolamide is available in 250 mg tablets. 250 to 1000 mg daily can be taken in divided doses. Sustained release 250 mg capsules, 250 to 500 mg daily, and 500 mg powder vials for injection, which is a single dose typically used in acute angle closure glaucoma. And there is dichlorpenamide. Dichlorpenamide, 50 mg tablets, 50 to 100 mg 2 or 3 times daily. And there is methazolamide. Methazolamide, 50 mg tablets, 50 to 100 mg 2 or 3 times daily. This is a longer duration of action than acetazolamide, but is less widely used. The side effects: the ocular, there can be choroidal effusion, particularly after cataract surgery. Angle closure may result. Systemic side effects: paresthesia, pins and needle sensations in the extremities. Hypokalemia, which is the reduced blood potassium level. It is common. Malaise, lower mood, gastrointestinal symptoms, renal stones. Stevens-Johnson syndrome is very rare. Dose-related bone marrow suppression. Idiosyncratic aplastic anemia, exceptionally rare but within 50% mortality. So paresthesia and hypokalemia is common. Another topical medication, medical treatment of glaucoma. Another option is osmotic agents. So osmotic agents, they lower IOP by creating an osmotic gradient so that water is drawn out from the vitreous into the blood. They are implied when a short-term reduction in IOP is required that cannot be achieved by other means, such as in the resistant acute angle closure glaucoma. Resistant acute angle closure glaucoma, or when IOP is very high prior to intraocular surgery. They are of limited value in inflammatory glaucoma. In inflammatory glaucoma, in which the integrity of the blood aqueous barrier is compromised. Side effects include cardiovascular overload as a result of increased extracellular volume. So it should be used in caution in patients with cardiac or renal failure, in patients with urinary retention, in elderly men, headache, with backache, nausea and confusions. The different agents are: mannitol is given intravenously 1 gram per kg body weight, or 5 ml per kg body weight of a 20% solution, over 30 to 60 minutes with a peak action within 30 minutes. Another one is glycerol. Is an oral agent, 1 gram per kg body weight or 2 ml per kg body weight of a 50% solution with a sweet sickly taste. Can be given with lemon, not orange juice, to avoid nausea. Peak action occurs within 1 hour. Glycerol is metabolized to glucose, and careful monitoring with insulin cover may be required if administered to a well-controlled diabetic patient. And the agent is, and the last one is isosorbide. Isosorbide is a metabolically inert oral agent with a MANTI test using the same dose as glycerol, which is 1 gram per kg body weight. It may be safer for diabetic patients.